about to dial into this HR conference call regarding my suspension in December. All right. Hello?
Welcome to the audio conferencing center. Please enter a conference ID followed by pound. You are now joining the meeting. Where at it? Is it? Okay.
Hi, this is Daniel.
Hi, Daniel. Hi. Can
Hi.
you hear us okay?
I can, yeah. Who's on the line?
My name is Sherry Crawford. I am an employee relations specialist with Colwell Health West. And of course, Savannah's on the line with us.
Okay.
So,
Hi there.
okay. Thank you for your time today.
Of course.
Appreciate it.
So what can I do for you?
I am conducting a fact-finding investigation. Some concerns have been reported. And part of that fact-finding is I would like to actually, can you hear me okay? I hear some feedback.
Oh, I'm sorry. Yeah, go ahead.
Okay. You hear me okay now, Daniel?
Yes, I can.
Oh, okay. Yeah, perfect. Part of that kind of investigation is hearing your side of the story, or of the stories. I've interviewed several people and identified some patterns of concern, and I just wanted to make you aware of those patterns and see if you had a response. Before launching right into it, I'd like to cover off on some kind of housekeeping rules that I tell everyone, inform everyone of that I interview. And after I mention those, if you have questions or need clarification, please let me know. When being interviewed by leadership and or HR, we expect that the information that you provide will be complete and accurate and a truthful depiction of any and all facts related to the matter at hand, the things we're going to talk about. The information that we're going to discuss, Daniel, should be kept confidential. So I would ask that you not talk with anyone about our conversation. And I keep my circle very small as well, just meaning that only those in a need-to-know position would know anything about this conversation. And lastly, as you know, Colwell Health does not condone retaliation. So I would ask that you not retaliate against anyone for participating in this investigation, nor should you be retaliated against for participating. So if you feel that you are, if you would please report that to Savannah or to myself. Do you have any questions about anything that
Not this far.
Okay. I'll jump right in. Some concerns have been brought up about concerning you with regard to procedural preparedness, sterility, as far as not being aware of the field, the sterile field, practicing outside of your scope, and those really are the patterns that I mentioned that are of concern. And I just wondered if you had any response to those concerns.
Well, I mean, I guess if there was more for me to elaborate on, I would, but I guess just in general, the concerns that you're bringing up are my preparedness. So I'm assuming when you say preparedness, you're referring to the materials that I need in the room. When you say something about my sterility, I'm assuming you're meaning the sterile field in general, and somehow this is what I'm getting from this, that some people think that my sterility is being compromised. And as far as practicing outside my scope, I guess what do you mean by that?
I am going to ask Savannah to jump in here. She certainly is more familiar with your work environment, and have her talk a little bit more about that. Is that okay?
Sure.
All right. So for the preparedness, you are correct with not having things ready for the case. Just things that you would normally open for cases, they're not open, they're not ready. That's as far as the preparedness goes, or waiting until the very last minute to scrub in and then ask for all of those things at the last minute instead of having them opened and ready and doing that sort of thing. The practicing outside of your scope of practice would be like the calling for calling the ED and getting orders, like what's going on with a patient, and adding cases, and performing those circulator duties that they normally do when they get add-on cases, just because they have those different things that they have been trained on what to ask and all of the things that they need to do when adding those urgent cases on with stat ORs and those sorts of things. The placing a Foley catheter, which we talked about as well already, that was outside of scope of practice, but that was just an example as far as that goes. And then was the sterile field, that was definitely a concern from the patterns with different team members, and physicians were, physician had an interview as well, and just being worried that sterility wasn't maintained. One of the examples was using the alcohol-based hand scrub and then drying it with a towel. And after learning that would defeat the purpose, like drying with a towel, you have to wait for it to dry. After learning that, you still continue to practice that way and not let the hand rub dry. Those were just a couple of the examples that come to mind offhand with the different interviews.
Okay, so a couple things here. You're referring to practicing outside of my scope. If I remember what you said calling down to the ER and booking cases that. What did you say about that? I'm sorry.
That piece was, it was a call situation, and you were getting the information that a nurse would normally get in their role as a circulator, and then you proceeded to call the staff in, instead of just calling the nurse and saying, hey, this doctor's got this case, and letting them find out all of the information that they needed to find out for the case. That was that particular situation, but it was just doing those duties that the nurse does when we get add-on cases.
Okay, so let me elaborate on that for a moment, if you don't mind. Was this case at night? Was it at a weekend? What's the situation here?
It was at night. I believe it was an evening that
Okay, well, I guess if I can respond to that, if that's okay.
Yeah, that's totally
Okay.
okay, Daniel.
So, if that's the case, if it's nighttime, and I'm assuming this is when I was still working my 3 to 11:30 shift, is that correct?
Yes.
Okay, so no one is there with me in the evenings, as you know, on Friday nights. And if Kim or Mallory wasn't there, I'm assuming it's a night either they had called off or that they weren't scheduled to work. Is that right?
Correct.
Okay, so let me just put this info in there. No one ever trained me, ever. Not one time have I ever been trained on how to proceed with a case at night when no nurse is there. Never.
Um, I mean, that wasn't gone over at all, that you would call the nurse, like, to call the nurse in? Like, you gotta call the nurse and let them know, hey, we got this case coming in?
During my education, I never received any sort of guidance relating to booking a case at night when no nurse is there. The only information I ever got was once I was placed in the evenings that these are the steps that you follow. And there's a checklist that's behind the charge desk. I went through that checklist. I can point. I know. I believe you know which checklist I'm referring to, but it goes down steps of what to do. It doesn't specify scrub. It doesn't specify anything else other than the steps to take at night. That is the only information I ever received. So if there was a case that was being brought at night, I followed that checklist by calling in the operator, having the people called in, nurses and scrubs, whatever they needed for the case. I usually spoke with the surgeons directly, and if I always checked too to see if the surgeon had checked with the anesthesiologist. Sometimes they never did. Sometimes I had to call the anesthesiologist, and I had to learn all of this by myself. So I guess that's something that I would urge the next evening shift, that if those are the responsibilities that are being taken by the scrub at night, then those things need to be taught during orientation. I had 3 different educators during my orientation, and not one of them ever went over that. Trista Watts, DJ, and Megan Eaton.
Gotcha. And I do know what checklist you're talking about. Those are like the questions that you would ask if you were to get a call in case, like obviously the patient's name, date of birth, if the patient's NPO, is there anything special that they need for the case? Those questions were all on there, and that list was created because I remember telling you that list was right there. If you were to get a case in, that would be the pertinent information that you would need to be able to get to the nurse when he or she was coming in for the case. Because I remember that list specifically, making sure that it was available. But obviously, you didn't have access to book those cases in the computer at all. And that was something that I was going to try to get done, but they said no because you guys don't have the privileges to be able to do so. But I do remember talking about that list with you and making sure that list was available. And I said that this was all of the information that the nurse would need for the case. And then you have to call you had to call the nurse in. And then typically the nurse would be the one to talk with the physician. So I do remember that list though of what you were talking about. And I'm sorry if that was not clear, or if education could have done a better job at going over the protocols on that particular topic.
Okay.
Okay, so regarding the Foley catheter, I know now that that is outside of my scope of practice. I guess where the confusion comes in for me, just personally, is some nurse assistants, because I came from the floor to the OR, some nurse assistants were actually checked off on being able to insert Foley catheters, straight caths, things like that. And the situation you're referring to was with Dr. Burson, I believe, and he had
Yeah.
he had told me what size catheter um, to place, and he had scrubbed out as I was still scrubbed in. He said out loud whatever the size was. I can't remember the size of the Foley catheter. Scrubbed out and expected me to do that. So I had seen it done, 1,000 times. Something that's not unfamiliar. So I did as he asked, and I even showed the nurse who came. I believe it was Jenna Wyan who came down after there was some complications with that, and asked me to show her exactly how I placed the Foley catheter, and I showed her, and she herself said I did it correct. I then spoke with Dr. Burson, and I showed him exactly what I did. He said I did it correctly. There was a second time that I had done, I believe it was the next day, and I had got Nick Urbina to watch me. I actually waved my hand because the same situation had happened. He scrubbed out, said the Foley size. Dr. Burson verbatim said, "I trust you," and walked out of the sterile field in Sisto. I waved to Nick Urbina because I felt like somebody needed to witness this, and I said, "Will you watch me?" He said, "Yes." I proceeded to do it the same exact way as I did the day before, and Nick said, "Yep, that's exactly how you're supposed to do it." So I was then told later by other staff, I was never told until the email that was sent to me that that practice was outside of my scope. So I never did it after that. So that behavior, I guess, was isolated to those two incidents.
Okay.
And I guess that's my side of the story if you're asking for it.
Yeah,
Yeah, absolutely.
exactly why we're talking to you. Um, can we talk about the sterile field
Absolutely.
and sterility? Yeah.
So
Um,
go ahead, sorry.
no, I was just going to ask you to go ahead and tell me.
Well, I guess the 2 points you made were not having things ready and opened in the room. I believe was the words that were used. A lot of times, the only things I don't have open are the things that I don't know that I need. Most of the time, I have things in the room, but there are many times with many surgeons, they go off of their own note card and they ask for something completely curveball. In my opinion, I don't think I can help that. I can have like things like suture. I can have a ton of suture in the room that I think that they're going to use, and they may not even use any of that suture. Things with robots too, for instance, those pieces of equipment are very expensive. Expensive as you guys know. I don't have those extra things open like the suction irrigator that costs well over $2,000 until the surgeon asks for that. So that will not be open. Um, I guess as far as things not being prepared, I don't really know what that means other than some of the last minute things like that I don't know that I need. So perhaps if you could help me figure out what that means exactly.
They didn't give like specific cases. They just said it's a generalized. You're not prepared, and you wait until the last minute to open things. It's things that are on a preference card that are as an open item, not a hold item, and then you wait until like the nurse is really busy in the room, and then ask for all of those things when it's at the busiest time for the nurse to be paying attention to the patient, because you're supposed to have everything counted and ready to go before the nurse goes and gets the patient.
Like scrolling like to the last minute.
Yeah, it's like scrubbing in at the very last minute, having ample time to get a case ready, but still waiting until the last minute to get it ready, and then just not being prepared for that when there was even extra time, like in the morning, to get ready for the case. But the sterility piece, that was for the preparedness, but the actual sterility is that there's a general consensus that they're concerned about your sterile conscious and that they're not confident that you can keep the sterile field sterile, and there's concern that there could be infections or contaminations for patients because they feel like they got to keep an extra eye to make sure that you're staying sterile, and it's just, I guess, overall sterile technique in your general like movements and things like that, and not being situationally aware of, I guess, the surroundings and the sterility. Does that make sense?
It makes sense. I guess my only thing that I would have to say about that is I disagree 100%. Everything else I guess we could talk about, the facts on and bullet points of, but sterility in itself, I feel like I am very aware of my sterility. So I'm not sure what this is coming from. I guess I would need a very specific instance because I wholeheartedly disagree.
Yeah, some of the examples that I was given was just like the generalized and the, like this has been like Sherry said, like a thorough investigation with multiple team members and a provider, and the provider being concerned about sterility in his patient. If they were to have mesh placed, that they would be concerned that there would potentially be an infection, that feels like they gotta kind of keep an extra eye out to make sure that you're sterile just in your movements and awareness of the sterile field. And I guess that was the other piece of it, was like the situational awareness, and just making sure that you're aware of what's going on. Like, for example, passing off a robotic scissor when the robot wasn't even docked yet, was an example that was given about just situational awareness. That was just one, I guess, example for that piece of it.
You said passing off a scissor?
Robotic scissor when the robot wasn't docked yet.
Okay, so
Off a regular scissor.
when you say pass off, what does that mean?
You get the robotic scissor and you're trying to pass that off to them, the assistant surgeon, when they're asking for a scissor, you pass off the robotic scissor instead of a regular scissor. I'm just trying to think of the examples during the interviews to give you some examples so that you can know and give your side and feedback.
Okay, well, if
Do you not remember?
I don't remember that. If I was passing off a robotic scissor instead of a regular scissor, perhaps I just got confused for a moment. I don't know how that has anything to do with my sterility.
That was more about like situational awareness, because one of the concerns was that it's the situational awareness and what's going on and being prepared. So anticipating the needs and anticipating what's needed next, and those the preparedness and situational awareness, and knowing, okay, well, I know I'm going to need this in just a little bit. I better ask for it and get it ahead of time. That kind of situation, I guess, if you will. I was just trying to give you some examples about the situational awareness and being prepared during cases too, and anticipating those needs.
Okay.
I can tell you, from all that I interviewed, there was a strong feeling of the unpreparedness part, waiting till the very last minute to get things prepared, and then even then not having what you need for a procedure, and having your fellow teammates running around you asking for things as the procedure is going, is progressing, and there were things that should have been already in the room and prepared for that procedure. That was a very, like I said, a very strong theme throughout the interviews.
Okay, has this been an ongoing concern for some time now, I'm assuming?
I believe your leadership was made aware recently, and
It was just recently that it was when I was on vacation that Leah was made aware, and that I guess she's kind of started talking to people, but it was recent. So it was right when I got back, and then we that was it.
in answer to your question, I got the sense that people have had concerns for some time. I can't define some time for you, but that it has gotten to the point that they are very concerned for patient safety.
Okay, this is the first time I'm hearing about this. So I guess my only rebuttal would be, why hasn't anyone said anything to me about this before? And if there was, I feel like in my own heart, I would have tried to fix those issues. I don't know why I'm deserving of suspension over some things that I could solve, but that's just my personal opinion. So I guess that would be my response to that. I feel like this is the first time I'm hearing about my unpreparedness for surgery. So forgive me, but I'm kind of caught off guard by this. I really don't know what to say. I have a loss for words that it's escalated to something like this that was never brought to my attention before.
Some of the team members have said that they've talked to you before and tried and have not seen things get better, and that you weren't very open to what they were bringing to your attention, I guess.
Receptive.
Yeah, weren't receptive. That was the word I was looking for.
Okay. I guess if that did happen, I don't recall right away who or when or what that situation was. If that did happen, I apologize, and I wish I could go back and collect some of the supplies that I needed, but I don't know of the situation. To generalize everything here is it's really difficult to try to keep a track of the things that I can change and the things that I cannot change. So to generalize all of this, saying that I'm unprepared for every single case, why is it that if I'm supposedly unprepared for every single case, my sterility's bad, I'm practicing outside of my scope, that I was chosen to be in the CRST program out of all of the other people that applied because they thought that I was good enough to do that. Not only that, but the day that I was pulled from surgery to come up to your office, I was teaching somebody in orientation. So if I'm so bad, why has this escalated to this point?
Well, I can tell you from an HR standpoint that Savannah was just made aware of this when she returned from PTO. What is you used an acronym, Daniel? What is that? C something or CR2 something?
CRST, it's Certified Registered Surgical Technologist. It's what I'm going to classes for, supposedly.
Okay, and you were chosen for that?
That's correct. There was an interview process that I sat with Leah in Savannah and Michigan, the state of Michigan, Michigan Works, and I believe LMC as well, Lake Michigan College. So there was 4 people at least in the interview, and they all thought that I at least had the strengths and qualifications to be chosen for that part. But now I'm hearing the exact opposite. So forgive me, but I'm kind of taken back by this.
When did that occur?
Just a few weeks
When
ago.
was that interview process?
This was
And that was,
a month ago, maybe more.
no, it was more than a month ago, but I do remember Lee and I also having the conversation with you that if there were other candidates that we'd be turning away for that we would have to let them join the program and not you because of the discipline, the corrective actions that you have on file, that we were going to give you an opportunity because we hadn't had any issues in some time, and you interviewed well. I was not aware of any of the team member concerns that were just recently brought forward at all, and I thought things were okay until these concerns were brought forward. But during that interview process, I do remember Lee and I having that conversation with you. Hey, we were gonna, there were some concerns from the rest of the interview team with the corrective actions that you had on file in proceeding in the program, and if there were to be any other incidences going forward up until when the program started in fall of 23, that we wouldn't be able to continue that. But we did, when we told you that we accepted into the program and stuff, Lee and I had that conversation with you.
And in procedures, how often would you say you can assign a percentage if you want? How often would you say that you have to ask your fellow team members in the procedure? I guess, Savannah, you might have to help me out here. The circulating nurses, how often do you have to ask them to retrieve things that were not already prepared for that procedure?
Okay, so I guess I have to distinct between 2 things here. Things that I don't know that I'm going to need, and things that I may need and have available that are not opened. So if we're referring to the things that, like for instance, suture or bandages at the end of the case, I really don't know in those situations what I'm going to need if it's a case like for instance, an open belly case, for lack of better words. Sometimes those things come up as we go. So I guess in those situations, probably half the time, 50%. But in cases that I'm very aware of what I need, I would say like 25% of the time. For instance, the hernia. I mean, you brought up the mesh a minute ago, so hernias are pretty straightforward. Really don't need anything with those. We do a ton of them all the time. Amputations, I feel like I have everything that I need, leg, arm, things like that. In the room, there's really pretty straightforward cases. Robotic cases, I don't feel like I have my nurse running around trying to do those things. I would say that the things that I need that I don't know that I need are usually cases where we're going in blind, and in my opinion, and I don't know what I'm going to need until we need it, or if the surgeon goes off of his or hers preference card. I don't know how to rectify that situation if it's not on the preference card and they're asking for something that I don't know that we're going to need.
Do you have Savannah, did you have a question?
No, I think the situations that were brought up are just, they're things that would be on a preference card that you should know that you need for the case. It's listed as a open item. It's not like a hold item or something that you wouldn't want to open ahead of time because you don't know what size you're going to need. It's not any of those types of things. It's just the normal things that you would need for a case. learn what some of those things are that are a potential that you could use, and you would get there. But the things that are being discussed are just the things that you know that you would need on the case. That you would need a blade. You know, that's not an exact thing, but just those things that are listed on there that you know you need light handles. You know you need a blade. The things that you use every case. Some of those things that you always use aren't ready, and that it's the waiting until the last minute to scrub in, or scrubbing out and then scrubbing back in the very last minute, and not giving enough time for counting and having all of those things that you need that are the normal things that you wouldn't normally have a scrub tech asking for, if that makes sense.
Does any of that sound familiar, Daniel?
I mean, I'm trying to understand the other side of the story. I really am. I'm doing my best here to try to recall things that maybe I gave my nurse the runaround for. And I guess that has happened for sure. That, like, I'm not denying that sometimes that does happen. I guess where I'm really taken back by this is that you're saying this happens all the time. I don't see that. I mean, if there is something that, I'm doing that could be done better,
Excuse me for interrupting. I don't know that it's done all of the time. I don't recall saying that. I do believe that it is done enough of the time that it's a concern to your fellow team members.
Okay, I can't rebuttal any of their feelings, I guess. If that's how they feel, then, it is what it is. And I feel bad that I made them feel that way, or that I gave them the runaround. So I don't really know how to respond to that, I guess, other than that.
Do you, I know this is a loaded question, but do you feel
This is so
you
stupid.
are a threat to patient safety?
I'm sorry, can you repeat that?
I said, do you feel like your practices are a threat to patient safety?
100% not.
Can you think of any reason why anybody reporting these concerns would be dishonest?
I don't believe that they're being dishonest. I believe that they're validated in the way that they feel. I just feel that their frustrations of me are turning me into looking like I don't know how to do my job. That's how I feel.
Why are they frustrated, though, Daniel?
I don't know. Apparently, from what I'm hearing, it's due to the lack of things that I am not opening or have available to them. So, yeah, I can't. I'm not going to tell them that they're invalid for feeling the way that they feel. If that's the case, then, I deeply apologize to the way they feel. But I feel like I have a lot of experience, that if I was the patient on the table, having the operation done on me, I mean, I know that my opinion doesn't really matter in this case, but in my opinion, I feel like I would be safe with me. That I would want somebody who has that awareness of sterility, which, again, I'm very caught off guard by that statement. I just wholeheartedly disagree with that. Everything else I feel like is, a matter of opinion, but this is very subjective. I just disagree with that wholeheartedly. I don't feel like I'm endangering the patients. I just don't agree with that at all.
I think concerning for me is that we heard similar things from team members and a physician. Yeah, that's just a statement, not a question.
Okay, are you looking for my resignation then? I mean, how is it you want to solve this?
No. Again, we
Yeah, I totally understand that. I get that.
Yeah. So, um, I'll go back and, review, all of my notes, including yours, and talk with, Savannah some more. And, Savannah will circle back around with you, when we have the next steps. Okay?
I totally appreciate that. I guess, forgive me for just being frustrated here, but my frustration is coming from, if I could just say that my frustration is coming from the fact that I feel like this could have been a pretty simple, educational experience coming from my manager rather than being suspended for something that I could change if I'm able to do so. I don't really understand that, I guess, and I'm very sorry for making people feel like I'm unprepared or that I'm a danger to the patient. I'm very taken back by this, so forgive me for my frustration. I'm just now finding out about all this, so.
No, it's okay. Um, and I apologize for continuing with another question, but, um, as far as timeliness, do you feel like you're as prepared as, as you could be? I mean, one account, I remember, I recall is, that a patient is already in the, procedure room and you're in the hallway or wherever, I don't know the actual area, but you're scrubbing. And it would be, I would think that as a layperson who doesn't understand any of the, technical part of this, that you would already be scrubbed and in the room with the patient. Is that not so?
Okay, so I guess I have a question for that. That depends. Has this been on my shift where I've taken over from 7 a.m. until 7:30 p.m., or was this on a shift where I'm coming in at 3 o'clock and staying until 11:30? Because if that's the case and there's a case happening, I'm only there at 2:50 in the afternoon. So I would be doing my. I could see how the perception would be that I'm not prepared if I'm doing my first day's scrub, and somebody thinks that I've been there all day, or if this is a situation where I just flipped over to my new shift. What, about 3 weeks ago? Not quite 4 weeks ago now. Of going from 7 to 7:30. I guess what's the scenario here?
It was the week of Thanksgiving you switched over, but these examples were examples after you switched over to your new shift.
Okay,
So
was I taking over for someone, or I mean, can you elaborate on that more?
That was not my understanding.
no,
Okay, I guess I
taking
don't.
over for somebody. There was multiple different examples. One of the examples was a case at the beginning of a day. It was the second case of the day, and the first case was in another room, so you had extra time to get prepared for that case. The first case was a shorter one. I think it was just an MRI report or something that should have only been like 30 minutes and was going till 8 o'clock. And that case, you weren't prepared for that even at 8 o'clock. Um, and you had extra time to get ready for it.
I believe this was Wednesday. Is that right?
One of the examples. What was that?
Was that this past Wednesday?
I don't recall the exact date from that one, just because, like I said, that there was multiple different interviews. Because we're making sure that we're doing a very thorough job of talking to different people, so it's not just one person's perception. But there was just different examples and different scenarios. But it was one of the days where there was two cases, and you were on the second case. I think that there was actually two examples similar to that, where you were given extra time in the morning.
Okay, so if I can only respond to actual, I can't respond to generalness. I can only respond to very specific situations. I feel like my memory is usually pretty good with specific scenarios. The only MRI port that I've ever done is the one that I was about to do on Wednesday when I got called up to your office, and I was scrubbing outside in the hallway. That's because I had an orientee. and I was showing her how to set up for this case. So I did not do my morning.
You weren't doing the MRI report. You were doing the robot in a different room. They were doing the other team of people were doing the MRI report or the short case in another room, and you were doing the bigger case. I believe it was in a robot room. It was a robotic case.
I believe this was last week then, because I vaguely remember scrubbing, but I also had an orientee with me that day. And I told her that I was going to scrub while she set up the table, very basically. So if that's the case, yes, I was scrubbing, but I was also teaching in the morning. So I can only respond to that scenario from what I recall.
One example, you did not have an orientee.
Okay,
on that one.
then I guess I just don't remember
I
this.
was just trying to pull up Epic so I could be more helpful to give details that would help you to explain it more. But yeah, you were not with an orientee that day. And the first case was not an MRI report; it was a DNC in another room.
Yes, this was last week.
DNC in another room.
I know exactly what you're referring to. I did have an orientee. She was not supposed to be my orientee, but she walked into my room and asked if she could help. So that's just my response to that. That is the only thing that's coming up in recent memory that I have not been prepared in a scrub to scrub before a case. So I can only respond to that specific scenario though. I guess I would just have to say, if you're referring to general things of me being unprepared, I'm willing to learn. I'm willing to, admit that I have mistakes and try to be more prepared for those cases. But I can only respond to specific scenarios, and if that's the case, I believe that was what had happened, and I believe I was training Emily. What the fuck, dude?
Well, the nurse didn't document any other scrub in the room for that case. I just opened up the chart to just see if there was an orientee. I looked at the sample to see if there was anybody assigned to that case with you. There wasn't, but sometimes you're correct, and somebody could just come in, but the nurses all are documenting who's coming in and out of the room.
This is so
within
stupid.
Epic in the staffing session, and there wasn't any other scrub that was in the room documented.
Okay.
Daniel, it's Sherry. Is there anything else that you think I should know that I haven't known to ask specifically?
I would just say that this goes back to what, in my opinion, I mean, you're asking my opinion. So, in my opinion, the things that you need to know is that I feel like a lot of this has to do with training. If the issue is that I'm not prepared, that 100% has to do with my education. And I don't want to point fingers at anybody but myself. But if I'm not being trained the correct way and I'm not prepared, I would say that had to do with my education. And if it's not brought to my attention, I don't know how else to correct these behaviors if I'm unaware of it. And if what you're saying is I was made aware from it from the nurse, what does that mean? Does that mean that the nurse made a sly comment like, I wish you would have been more prepared? Well, I take that as frustration, and perhaps, yes, I could have been more prepared, just in general. But unless something is brought to my attention very specifically, Daniel, we're noticing these patterns. You need to change this, this, and this. I never had that. I never had anything brought to my attention that way. So I guess in my defense, I can't change those behaviors if I'm not made aware of them. So, I mean, is there something that maybe I'm missing in general? Am I just completely unaware for every single case? I mean, what are the things that I can do to help my teammates, help my team members, keep the patient safe, stay trained. I mean, I would love to change, but at this point, I don't really know. When you're bringing up things in general, I can't respond to generalness. I can only respond to specific things.
I did not, when I was talking with those that I interviewed, I did not get a sense that they felt that you were not properly trained. It was more of what I sensed from them was um, there was a lack of urgency, a lack of, not a lack of, but feeling that it wasn't necessary to be prepared from your standpoint because you had others in the room who could be at your beck and call and get things that were not um, prepared like they should have been. That was my sense, Dale. Not a lack of training. In fact, I don't think one person said anything about, I don't think he's received enough training, anything like that.
Okay.
And I don't know if you have any.
No, I don't think so. I think, and honestly, we did more of an extended orientation to make sure that you were prepared for going on to the 3 to 11 shift and making sure that you were laser trained and all of those things and giving those extra bits of time to say, hey, is there any other cases that you're not comfortable with that you need to get back into so that you can do those on the 3 to 11 shift. And your orientation is extended a little bit longer just because of the shift that you were going on to. Because it's harder to get some of those opportunities on that shift than during the day. So I do remember doing that as well.
And was there anyone that you believe I should talk with who can, in essence, verify the right word or not, substantiate